Hello, my name is Charlene Rio, and I will present you our study about increasing survival of newborn mutant mice in the CCHS model by a non-invasive positive pressure mechanical ventilation. I work as a MD in the hospital of Robert Debré in Paris, and in the 1141 unit at the INSERM in the same place. I don't have any interest conflict with that study. CCHS is a rare genetic disease which incidence is about 1 on 150,000 live births. It is clinically defined by hypoventilation, mainly during sleep, but also during the day in the most severe cases, with apneas and reduced or absent ventilatory chemosensitivity hypercapnia. There is no specific treatment for, and patients require a lifelong ventilatory support, or in rare cases, diaphragmatic stimulation. CCHS is caused by an heterozygous mutation on FOXP2 gene that encodes a key transcription factor in the development of the autonomic nervous system, and in particular the neuronal circuits involved in respiratory reflexes. 90% of patients have an alanine expansion on FOXP2 from +4 to +13 alanines, with a normal expansion about 20 alanine. The length of polyalanine expansion is correlated with clinical severity. 10% of patients have missenses, no sense, or framshift mutation. The most prevalent mutation in the 7-alanine expanded stretch. We have a mouse model of CCHS in our lab. It's obtained by a knock-in of the most frequent mutation in humans, the addition of 7 alanines. This model have been analyzed in previous study. And at birth, mutant pups have a hypoventilation and no response to hypercapnia, as you can see in black just over here. The mutant pups present more apneas than the wild type, and we recently demonstrated that a lot of those apneas are obstructive ones. At birth, mutant pups are cyanosed and die very shortly by respiratory arrest. In vitro previous studies shown that polyalanine expansion causes cytoplasmic retention of the mutant FOXP2 protein and aggregate formation, resulting in impaired transactivation activity. Drug screening has shown that the antibiotic, jadalmicin and its derivative 17-AAJ, which are heat shock protein inhibitors, can clear mutant FOXP2 aggregates, restore the nuclear localization of FOXP2, and rescue the transactivation of target genes. Our mutant pups die very shortly after the birth, as we can see on the survival curves. Almost 50% of the mutants die within 3 hours. This life expectancy is not compatible with any pharmacological study. For example, gildanamicin needs 6 to 8 hours to be effective. So we had to find a way to ventilate the pups, but it was a real challenge due to the size of a newborn mouse and his weight. I don't know if you ever seen a baby mouse, but it is really small, like 2 or 3 centimeters, and weighs around 1.2 gram. So you can easily imagine the technical issues. First option is invasive mechanical ventilation. And it's impossible due to the equipment required, which doesn't exist. In particular, the resistance of the endotracheal tube could be too great. The second option is diaphragmatic pacing. It's not impossible to chirurgically implant the device, and we have some difficulties with anesthesia and the size of the mouse. The only option available is non-invasive mechanical ventilation using a face mask. We then hypothesized that non-invasive positive pressure mechanical mechanical ventilation could prolong the survival of our mutant mice. We developed in our lab a device composed of a face mask and 2 pneumotachographs. In order to avoid the leaks, we applied a fast polymerization dental paste, which hardens but remains easy to remove without hurting the pup. A pressure generator on the expiratory line allowed to generate the pressure in the circuits, and we could measure the pressure with a sensor. The ventilatory parameters were determined in a previous study with the aim of mimicking the normal spontaneous ventilation of a pup at birth. We use positive pressure with an inspiratory pressure between 5 and 8 centimeters of water to deliver a tidal volume of 10 microliters, with a positive and expiratory pressure between 2 and 3 centimeters of water. The respiratory rate was quite high and was between 1 and 1.5 Hertz. Our device can accommodate and ventilate 6 pups at the same time in these 3 controlled rooms. You can just see here 1, 2, 3. Pregnant mice were placed under video surveillance so that we could monitor births, and as soon as the birth started, we took care of the pups and we measured temperature, weight, and Apgar score. Then we randomized the mutant in one of the 2 groups. Either the animal is placed in the spontaneous ventilation group or in the mechanical ventilation group. During the first 4 hours of recording, we manually switched between spontaneous ventilation and mechanical ventilation according to the need of each pup. We turned on the ventilation when hypoventilation or apnea greater than 10 seconds occurred, and we turned off the ventilation when the pup struggled against the ventilation machine to avoid the complication of mechanical ventilation. In each group, we evaluate the survival rate at 4 and 12 hours. Here we can see survival curves in the ventilated group in red and in the non-ventilated group in blue. At 4 hours of life, 88% of the ventilated group is alive against less of half of the non-ventilated group. This result is confirmed at 12 hours of life, where we have more than half of the population of the mutant pups alive in the ventilated group. After this period, we notice that the 2 curves tend to meet and finally cross, corresponding to other mortality factors such as fasting, absence of maternal care, etc. Finally, we validated our hypothesis. We managed to prolong the lifespan of the mutant pups. During the first 4 hours, mechanical ventilation, when applied accordingly to the need of the pups, prolongs the survival of mutants. This is finally the first step for the study of the effect of acute drugs administration in our model. Our protocol needs to be improved, in particular by adapting in an inspiratory support mode rather than a controlled pressure mode. We are currently developing a protocol for feeding mice by intragastric injection of milk or glucose solution. One of the most interesting application of this technique is that it can be applied to other mouse models with high neonatal mortality due to respiratory distress. There are at least 45 mouse genetic lines in which the pups die within 48 hours of respiratory arrest after birth. So our technique could prolong the lifespan in order to study the phenotype, physiopathology, and why not test some drugs. That's it. So thank you for listening, and now it's time for questions if you have some.